I'm the president, as Jean mentioned, of St. Joseph Mercy Oakland. We sit on Woodward Avenue, just north of Square Lake, and my hospital is a member of Trinity Health, which is a national Catholic health system with 94 hospitals across 22 states, just to give some perspective on who we are. From a regional perspective, I'm a part of the St. Joseph Mercy Health System, and we have 7 hospitals within the state of Michigan and hundreds of employed physicians and physician locations. So again, just to give a sense of size and scope and who we are, St. Joe's Oakland is the only Trinity hospital in Oakland County, and we've been here since 1927 and very, very committed to our community, just as I know my healthcare colleagues are as well. So when COVID came to our community in early March, we really did not have much time to implement the changes that we had to implement to keep patients, colleagues, and our community safe. And, just kind of looking back on this experience, it's stunning how quickly we all went from being full service hospitals that do hundreds of surgeries in the course of a given week to really contracting our business model, putting a pause on scheduled surgeries that we could hold on, and really focused on treating patients that were suffering from COVID. And that change happened as I look back. Our first presumptive cases in the state of Michigan came at the beginning of March. And by mid-March, we really had put a bunch of change into place, including pausing our surgical volumes. And the way that we were able to adjust that quickly was really through a robust incident command structure. Those of us that work in healthcare are accustomed to being prepared for emergencies. And I think our practice and preparation has served us incredibly well during this period of time. Being part of a national health system helped. If you can't help but watch the news and hear horror stories about PPE shortages across the country. And, one of the many reasons that I'm grateful to be a part of Trinity Health was the pipeline of PPE that we were able to secure to keep our colleagues, our physicians, and our patients safe. And the other thing I want to share before I get into talking about our first of 3 topics is the outpouring of support from our community was incredible. Food donations, monetary donations, just different signs of support. And for those of you that donated, for businesses in your community that donated, thank you. The material donations are helpful, but the additional psychological benefit that staff get when they see a community really rallying around them during a difficult time like this, I think it really helped to pull people through what was a very, very difficult time. The first question, Jean, that you asked us to contemplate is how has our business changed during this period of time? And, as I mentioned, we went from being full service hospital to really having to contract and think about how to care for patients in different ways. And so some of the things that we see different, we've seen a huge rise in the use of telemedicine as a modality. Many of us have used telemedicine in the past, but this really forced us to implement telemedicine as a way for physicians to connect with patients. And I think that we're going to see some sustained positive change and adoption of telemedicine in a more robust manner, in large part because it's worked during this period of time. It's convenient for patients, and physicians and patients have really grown accustomed to connecting in this manner. We also learned, I described the incident command structures that we put into place, and we, up until very recently, have had daily incident command meetings related to COVID, where we have monitored daily our PPE supply, volume of patients coming in, number of colleagues that are ill, et cetera. And we will be maintaining a supply of PPE in the event that we have a second surge. We've heard some information that leads us to believe there could be another surge this fall, and we all just want to be prepared for that. The collaboration of area hospitals, I know Margaret's on this call somewhere, I see you over there. She's my neighbor in Oakland County, and we've exchanged everything from isolation gowns to masks. It's just wonderful to have that kind of collaborative support. And I know across the state of Michigan, our health systems collaborated with state government to help provide guidance for how do we, what services do we pause during this time? how do we manage visitor traffic into our facilities so that there's consistency across the state, which we know is important. We also, during this time, our business, healthcare can be a pretty complex business to navigate. And we have been evaluating and taking advantage of this period of time to really look at how do we interact with our patients and with the community, and what opportunities do we have to simplify and do things differently in light of the fact that we had to rapidly adapt to a very different environment with very little notice. We still have visitor restrictions in place that will be changing this week. But during this time, we were on very limited visitor restriction within St. Joe's and within hospitals across Michigan. And so we had to turn to different technologies because it's really important to keep patients and families in touch with one another. We here migrated to the use of iPads and FaceTime between, we had staff that would help to facilitate those connections. There was one in particular that I was involved in. This was a gentleman that was admitted, and his son was living out of state. And it was very, very important to them to connect with one another. So we were able to facilitate this connection. The gentleman didn't have a smartphone of his own. And the difference that it made for both of them is just one of those things that, that you hold on to and you won't forget. And I think there's opportunity to continue to advance those types of technologies in healthcare. We've seen changes in consumer confidence kind of coming out of this period of time, and a reluctance for patients to come into the healthcare environment. And I think we've all got some work collectively to do in that space. I know I saw data recently from the Oakland County EMS provider group, and there was an extraordinarily significant increase in deaths at home during the month of April and May, almost a twofold increase over prior months, because there was such hesitancy for people to call 911 or go seek care in the emergency room for non-COVID related reasons. And so I know my colleagues and I are all trying to get the message out that we are safe and prepared to take care of you. We're seeing a change in that behavior now, which is good, but that's something that we've all been incredibly concerned about. I'll talk for a minute about the financial impact of COVID. If I talk about data across the state of Michigan for Trinity Health, we've experienced about a 50% drop in our patient activity during this time that resulted in an operating loss of $50 million in the month of March and $84 million in the month of April. And I know when I talk with my family members and with my friends that don't work in healthcare, they can't fathom how during a time like this, healthcare providers could be financially impacted in an unfavorable way. And there's a couple of reasons for that. The reimbursement models for surgical and medical patients are very different in healthcare. I'm sure you've heard about this as you've read the news in the papers. And the patients that we cared for that were COVID positive, generally speaking, had long lengths of stay requiring lots of ICU time. And the reimbursement just doesn't always fully cover the cost of care for those types of patients. So we've got some significant recovery work to do, as I know many of our businesses in Oakland County are in the same position. I sit on the Oakland County task force related to COVID recovery, and I know that we're having a lot of these types of discussions across the county as well. There was a second question that was posed related to the lasting impact of these changes. And I think as we're transitioning out of this period of pandemic, we're now in this period that we call coexisting with COVID. COVID is not going to go away. It will probably be with us even after a vaccine is available. And so there are permanent changes that we're making to how we care for patients, again, with patient safety and staff safety top of mind. Some of the things that are different, we test patients before surgery, and there's a drive-through testing center on our hospital campus that we use to facilitate that testing. And that's a change to the pre-surgical workup that patients go through. We've identified what we call COVID-free zones, and these are areas where we cohort patients that are either COVID positive or highly suspected of being positive for COVID, separate from the rest of the population, just so that we're keeping all of our patients safe. We're just like everybody else in Oakland County, screening all of our staff and our visitors at every point of entry, including temperature checks, which, you know, it's an added burden and resource that we've got to have in place to facilitate that. So those are just a couple of examples of some of the changes that we've established. You know, the other thing, sitting here in Pontiac, there's an underserved population that during times like these, things get even more difficult for that group of patients and our community members. And we've established social care hubs within our community to address things like food insecurity, transportation needs, people that don't have health insurance and need access to care, medication affordability, and other needs. And we've actually established a hotline that we've published so that people that need help, it's one call away for us to step in and provide support, and particularly during times like this where folks are perhaps unemployed, perhaps temporarily laid off, and social isolation has kicked in because of all the social distancing we've all had to do. These issues tend to become that much more pronounced. So we felt it very important to take a firm stand in this space. The third area that you asked us to touch on is kind of to speak to how the business community can help us and help local hospitals. And, you know, hospitals tend to be, I don't know if I want to call it an economic engine, but we tend to be big employers of people and communities. And so our recovery from a financial perspective from this period of time is important, of course, to us as we serve patients, but it's also important to those that we employ in our communities. You know, we continue to emphasize all of the things that you hear about from the governor and from the news, the importance of social distancing, the importance of wearing masks. We have a universal masking protocol in place at St. Joe's Oakland, and we believe that alone has had a huge impact on limiting the spread of COVID among our colleagues. If any of our businesses in Oakland County have questions or need support, particularly as they start to ramp back up to open up, we are here to answer questions and provide support. I don't want to speak on behalf of my colleagues, but I know that they feel the same. We really want to come together as a community to help our Oakland County community come out of this. And I think I'll pause there. I think you're going to hold questions at the end. Am I right? Okay, good. I hope that was helpful.
Yes. Thank you. Okay. And Chris Palazzolo, President and CEO of Ascension Genesys and Ascension Providence Rochester Hospital, you are up next.
Thank you. You know, much of, and Shannon, you did a fabulous job as always, but much of what you're going to hear today is a similar theme that runs across all of our hospitals in terms of how we reacted to the pandemic. At the end of the day, yes, we're competitors, but we're brothers and sisters in arms here. And many of the tactics, those first couple of weeks, we relied on each other to kind of put together best-in-class opportunities to streamline how we were reacting to this. But it was unlike anything any of us have experienced in our careers, and hopefully we won't go through that again in the near future. But very similar to how Trinity stood up their incident command center, we stood up our incident command center from an Ascension perspective, which is a large national health system, 150 hospitals, 14 hospitals in Michigan. We did it at the national level, the state level, then each of our individual hospitals. And many of us who have been around for a lot of years have been through incidents and where we had our incident command centers put in place. But the word incident generally infers that it's going to be over soon. A snowstorm, an external disaster, something of that nature. Not necessarily a 2.5-month incident that requires incredible attention and resources and coordination at multiple levels with each other and with our fellow hospitals and with the state. So we took a very organized approach to that, and it was amazing. In fact, the process worked so well over time, as hectic as it was. We are now in a debrief posture where we're trying to take lessons learned from that experience and how can we fast track some decision making. Hospitals, especially hospitals in larger health systems, tend to take a while to make decisions. And this opportunity for quick decisions, there's really some learnings that were focused in the incident itself that we're going to take And I would say, and this is kind of just, I'm morphing into your first question or topic about how healthcare has changed in the current environment. And I would say developing mechanisms to account for what will be a parity of services, and we will have a plurality of services in that we have COVID and non-COVID. So how do you redesign your facility to be able to account for those? Not just in terms of physical split flows, but it's how are our care models changed and altered for that? I agree with Shannon. There's every indication that there's going to be another spike and before the vaccination, and then even after that, COVID's going to be with us for a while. And that thought strikes a little fear into our hearts, but going through what we've been through the last 2.5 months, we're less fearful of the unknown because we know we can react. The other thing I want to emphasize that maybe goes without saying when you look at the mortality numbers, this was an incredibly sad time. It has been an incredibly sad time, not only for our families and their loved ones that they lost, but our caregivers. You know, we've had incredible stories. We have lost some of our caregivers, sadly, across the country. And in particular, our young physicians, our residents, who were pressed into action working outside of their specialty, physicians volunteering, working outside of their specialty. Some of the stories are not only heroic, but incredibly sad. Residents in a 12-hour shift, what they had to deal with in the ICUs when many patients did not survive their illness. So that, I think that's changed us individually, and especially those on the front line forever. There is a lot of our attention now is helping folks through that process, the post trauma, if you will, and how we can really embrace them and make sure they're cared for as we go forward. The other piece of that is essentially as we look at opportunities, and this is kind of morphing into your second comment, what did we see that change that we can continue? So as Shannon indicated, telemedicine has been around for a while. It's not a new concept per se, but our ability to use it was somewhat mitigated by regulatory concerns and billing concerns, billing and collection concerns. Several of those, the Medicare, CMS, and local insurance companies lifted those, we're hoping permanently, not temporarily. So the payment mechanisms and the schemas were such that it became more advantageous. We went, just for our employed physician groups across Southeast Michigan, so those employed by Ascension Medical Group, we went from 250 virtual visits a day to over 5,000 a day. Now that's throttled back as we've opened the gates a little bit, but it's still upwards of 3,000 virtual visits per day in our physician offices. Folks are getting more comfortable with that technology. And I think that is an everlasting change that just was able to get a catalyst, a spark to move forward. And I think in the physician environment, you going to see your physician, that will continue. If you do have to have ambulatory services, if you do have to have a procedure, you're ultimately going to have to come to the hospital. But I do think that is a very significant change that will stay. The other, I would say, a moment of truth that we reached is the impact that the coronavirus had on populations that did not have access to adequate health care. So the disparities of care specifically for chronic disease. So what will that do and what can that do? Again, it goes back to incentives around caring for a given population and frankly being rewarded for optimizing the health of that population and keeping them out of the hospital. We've been in this fee-for-service world for, since Medicare and Medicaid, the mid-60s, and moving towards a fee-for-value where providers, hospitals, physicians, and others are rewarded in a manner that's more consistent with optimizing their health. That then gives you an opportunity to move into populations where there is a disparity of care and not only improve the wellness, but lower the utilization of hospitalization and procedures, unwarranted procedures in some cases. So we need to continue that and use this, like the old saying, don't let a good crisis go to waste. We need to emphasize the use of technology on one side, but also alterations in payment schema that will allow us to better serve all the populations we take care of. The other reality, the stark reality that many of our hospitals across the state of Michigan and the country are dealing with is the disproportionate negative impact that this disease had on rural hospitals and small hospitals. Their ability to withstand a body blow, all of the hospitals on this call come from a strong regional or national base, so they could take a hit to the gut, if you will. And the financial implications were significant, as Shannon indicated. But our small hospitals are living on the edge. They are literally at risk, and they serve those communities. They are in some cases, the sole provider in those communities. They need support, and they're going to need additional funding to get through. Again, as Shannon indicated, the amount of as we turn the dial back up to allow more elective surgeries and those surgeries and procedures that were postponed over time. And we're doing that slowly at Ascension to make sure that we have adequate testing and PPE available. So we're stair-stepping that in. You know, we have this fear that people don't want to come back. You know, we spend a lot of our time, I think the four of us, coming up with tactics to how to convince the public that it is safe to come back. Of course, when they come back, they're greeted by folks in masks with lots of questions, checking temperatures, and doing all those things that frankly restaurants are doing, but you know, it doesn't appear that it's a very welcoming environment. And we did get a bit of a fastball over the last 24 hours where Michigan was opened up for more liberal visitation. So we're being very, very quickly reacting to that and assuring that the expectations of our visitors, which based on phone calls is quite high, effective immediately, to come into our facility and walk anywhere and visit is not quite as liberal as they might think. So we've done many of the same structural, those of you on the call who have businesses large and small, we've done all of our hospitals have done the same structural changes to assure cleanliness, sterility, safety of those who are in the building and those who are not. We were talking shortly before the call started about the number of non-frontliners or clinicians that are now working from home. That has, again, been a tidal wave of change, some of which is going to be pinned on our ability to make sure the technology platforms are appropriate. But departments like HR, finance, information technology, it goes right down the list, research. Those folks have been at home since the second week of March. And we know for sure they're not coming back until after Labor Day. And beyond that, Ascension nationally is assessing by job classification who's going to stay home and who's going to go to work. Some will go to work 1 or 2 days a week. Others will work from home. So it takes a lot to get used to, especially if those of us who've been around 100 years and can't quite get comfortable with the concept of working at home. But that's just me. Others are very adaptable and look forward to that opportunity. In terms of getting folks back to our hospitals, in addition to showing that we're safe and that we're available, we are concerned about the rise of unemployment and the potential diminution of health benefits for employees. So that will have a negative impact on our ability to perform some of those more profitable surgeries and procedures that we do in our hospitals. And you know, we struggle for a 1.5 to 2.5 to 3% bottom line is a remarkable year for our hospitals. And if suddenly any of our profit opportunities are taken away because those patients aren't coming or no longer have insurance, we'll definitely be in negative territory for quite some time. And I think the last topic you mentioned was how can the business community help and be collaborative? I would say encourage your constituents that our facilities are open and safe. We spent a good bit of time trying to do that, but to the extent you have that opportunity, we have really, just like you've gone out of our way to make sure our facilities are safe. There are still 25 to 30% of the patients who are not going to their physicians, their primary care physicians. So encourage your employees to go to their primary care physicians. As Shannon indicated, the amount of mortality at home or to the hospitals I've seen 3 counties, Macomb, Oakland, and Wayne, and in all 3, it more than doubled. Wayne County was more than double. So that's again a very sad part of this, is the deferral of cases for people who are in fact sick. We spent a good bit of time, as I'm sure my colleagues did, in the first 2 weeks. Of where did all those emergency department visits go? We were down to about 20% of our normal volume, and they were all COVID. So where were the heart attacks? Where were the strokes? It's quite remarkable what happened during that period of time. I would encourage your constituents to use our community services. We have many outreach programs for various wellness opportunities. And again, speaking to those who have struggle to receive access to care, we have clinics, we have education, and we have long ago established that. We have doubled down on that, increasing locations, as well as hours of operation and resources for each of those community outreach centers. And lastly, I would say just communicate, ask any questions, concerns that you have. We're all here to address those. There's no time for rumor and innuendo. We are here to help. We're prepared to help. It's what we do for a living, and we're structured and built that way. So don't hesitate to ask if you have any questions. That's about it.
Okay, thank you so much, Chris. All right, next I'm going to turn it over to Margaret Dimond. Margaret is the President and CEO of McLaren Oakland. Margaret?
Thank you. I hope you can hear me. I'm doing this by phone. The computer, we're having some server issues. And I want to say hello to my colleagues. It's good to see Shannon and Chris, and about to listen to Nancy. Shannon was very eloquent, as was Chris, in terms of all the things that all the hospitals have felt. McLaren is a system. We're not a national system, but a state system. And we are set to lose over $100 million because of the pandemic. And so when you think of the economics, you really just can't make that up in a year. And all of us are uncertain in terms of, what next year is going to hold. But the other nuance of McLaren Oakland is we actually had the first COVID death in Oakland County and the 3rd death in the state. And I will tell you that we were certainly not prepared. The patient was a 52-year-old who came in, who was a chronic asthmatic, didn't have COVID signs, and came in through our ER. At that time, it was pretty much the first or second week, and we weren't prepared with masking and gowning. She went from the ER to a general medical floor, then progressed in her illness to a step down. We did a COVID test, but at the time, the COVID tests were taking 10 days to 2 weeks. And on day 5 in our ICU, she passed away. We were not able to find out that she was COVID positive until 3 days after her death. And she had touched 45 of our nurses, respiratory therapists, ER staff. And so all 45 of those overnight, once we found out the diagnosis, had to be quarantined at home. And if you think of a hospital losing 45 staff at any given time, that was a crisis from the very start of the pandemic. So really what we were looking at is, how has this impacted healthcare? Well, because if you have 45 of your colleagues at home and worried about, are they COVID positive? We didn't have the testing yet. The stress of the entire hospital elevated almost to a fever pitch. The nurses were afraid. Then when, as my colleagues have said, our OR and ER dropped off, so we were having to redeploy our ER staff to the floors and our OR nurses to the floors. And anyone out there that would ask an OR nurse if they'd like to go to a general medical unit or an ICU unit, they will tell you, no, thank you. So we had to develop what we called as team nursing, because the OR nurses didn't know how to document on our EMR. So we had to go to paper records overnight for those OR nurses and develop a team nursing model where the ICU nurse was in charge of a group of patients. Again, what they weren't used to, they're used to a 1-to-2 patient ratio. and the OR nurse was sort of like a runner for the ICU nurse. So again, rapid cycle learning of how to completely change caregiving within a hospital in literally a week because of the number of staff that we have 8 respiratory therapists in general on a shift, and we went down to 2. And the patient exposed over half of our ICU RN staff. So that was the immediacy of our staffing crisis. And my colleagues will understand, and they've gone through this too. Typically when we're short on staffing, we call agency help. Well, the agency staff were not wanting to come in to the hospitals because of the COVID crisis. And so there was no outside help, if you will, to relieve our staff. So we were having staff working double shifts. We actually had staff that were living more than 25 miles away, sheltering in, and we were either in the beginning paying for them to be in a hotel, but then when the hotels really weren't accepting patients, they were staying in a unit that we had closed down to consolidate. So very different way of caregiving for our patients. The other thing is that typically in healthcare, we're very defined in our roles. Transporters transport, lab staff do phlebotomy or specimen collection. All gloves were off in this fight. We had managers transporting patients. We had facility people helping EVS clean the rooms and sterilize the rooms. So it really had to, whatever your title was or HR job code, that was secondary in the pandemic. We needed to do what was needed at the time. And I think the other thing, and Shannon and Chris touched on this, is a hospital is also a teaching institution. We have learners, we have nursing students, PT students, we have medical students and residents, and all the rotations, and those are assistive to our staff, all those rotations were stopped. So that was a huge change in terms of the culture and the day-to-day operations in managing the staffing in the hospital as well. I think when you look at how this is going to change healthcare going into the future, one thing my colleagues touched on is, working from home. The thing that we're experiencing, I'm sure all 4 of us in our healthcare systems, is not only furloughs, but permanent layoffs. And in numbers that we probably have never seen before, because we don't know what the new normal is. So that affects not only the stress of the staff that are here thinking, am I next? But we're also, as Chris said, there are people working from home. Now we're starting to bring people back in McLaren. What we're finding is they have stay-at-home syndrome. Now they're afraid to come into the hospital, and they're asking if we can elongate their stay. So it's, creating sort of stress between our HR folks and, the staff, and some, I guess, concerns in terms of, well, if I come back, can I just stay in my office and I don't want to, walk around the hospital? So just still a lot of fear in terms of I'm vulnerable and I don't want the hospital environment to continue to make me vulnerable. And in terms of scale of services, you'll hear this from all of us. We don't know what the scale of service is going to be in the future. There are some areas that we've all shut down, and maybe those services will be shut down for the next 6 months or year or never opened again. I'll give you an example of our sleep center. We shut that down right in the beginning of the pandemic. We're not sure that we're going to open that again. Will it be safe? Will it be solvent economically as well as, with exposure? So those are all questions that I don't think any of us can answer right now. In terms of the public and the visitors, I know my colleagues brought that up, but I want to emphasize that at least in downtown Pontiac, that was an issue for us because there were 2 types of visitors. There was the visitor that was had gloves and wanted to wear 2 masks, and then there were the visitors that really believed that this wasn't going to affect them, and we had some families that felt it was, a hoax. So trying to get them to be compliant was very difficult, and that was previous to, the no visitation policy. Finally, I'll talk about the business collaboration. Being in the center of Pontiac, it was different for us because a lot of our businesses, for instance, the restaurants right in downtown Saginaw, they were in jeopardy of, not only closing, but losing their businesses. So as we were contacted by generous donors to provide meals for our staff that were working on the front lines, we were recommending our business partners in Pontiac to be the restaurant of choice. So that's at least helped some of them get through. I think in the future, as Chris said, our business partners can reassure their constituents that hospitals are safe, that they are sanitary, and that we're open for business, because I think that will be a message that needs to be repeated over and over again. The other thing in terms of collaboration, we got an outpouring of businesses, for instance, GM and Ford, their specialties obviously are automotive. GM donated to our hospital at least 20 boxes of masks and face shields, likewise Ford. So if this does surge again, we would rely on our business partners to continue to collaborate with us to keep our workers safe with the most essential protective equipment. So I'll stop there, and I know we have questions at the end.
Thank you, Margaret. Okay, and last but certainly not least, Nancy. This is Nancy Susick. Nancy is the president of Beaumont Royal Oak, previously the president of Beaumont Troy.
And thanks everyone for being here this afternoon. I appreciate being able to be here with my colleagues, and you're going to hear much of the same thing from me that you've heard from my colleagues, and we've all experienced very similar things. I am the president at Beaumont Royal Oak. I've been with Beaumont for about 35 years, and I'm a nurse by background, and I've also spent 24 years with the Navy. So I had a lot of experience in the past with some of the incident command structures. But in terms of Beaumont Health, Beaumont's Michigan's largest healthcare system. We have 8 hospitals, 145 outpatient locations, and nearly 5,000 physicians and about 38,000 employees. So we definitely have seen a real impact. It was wonderful to have such a large organization to rely on, but we certainly have a lot of employees and staff that were definitely impacted by a lot of the things that had occurred over the last many weeks. The pandemic, I think, as we all know, took such a toll on all of our hospitals and businesses and healthcare in so many ways. And I think with Beaumont and some of our other organizations, being that we were large, we were able to collaborate and coordinate things at many times. However, even with that collaboration, there was a lot of challenges that we saw over the time. This happened all extremely quickly, late 2019, cases in China. And then here in January, we started seeing things coming through the United States and a lot of things being shut down, airports and so forth. And then, of course, our first case here in Michigan on March 10th. Our first case at Beaumont was in March 13th. In our region, Beaumont responded quickly and cared for the largest number of COVID positive cases. And at one point on April 6th, we peaked at 1,200 cases. The majority of those cases were seen here on the Royal Oak campus. And initially, because of our planning in the past, we had some great response, but we extremely got busy in our ERs, our ICUs became very overwhelmed at capacity. So we had a lot of things to do in terms of supplies and staffing and so forth. But as I can't emphasize enough for the community to know, these incident command centers that you've heard my colleagues talk about, this is, I really feel, what really got us through. We plan, we have teams designated that plan even beyond just one day type of things, because it's important that we stay connected. We also have a lot of collaboration with the community in terms of state, county, and local resources, law enforcement, fire departments, EMS services, Michigan Department of Public Health, CDC, and many, many others. And in January here at Beaumont, we created a coronavirus task force. This was even before we stood up the incident command centers, just to start planning, had our infection control practitioners trying to look forward as much as possible on what we were going to need to do. And then in February, we created a command center at our corporate offices, but then at each of our hospitals, we created those command centers too. And that's how we coordinated the PPE, the protective equipment, mask, gowns, gloves. And we were running out of certain supplies at each place, but we were able to move those around because of the transportation system within our hospital to make sure each of our sites, as we got busier, were able to have those supplies that we actually needed. So that was really good. But as our other colleagues in hospitals had changes, we certainly had a lot of changes in our inpatient care. Our volumes were significantly decreased with non-COVID patients. Our ERs were really busy with COVID patients and non-COVID patients. And there was just a lot more activity that was occurring. So a major, major change in our hospital operations. With surgeries being canceled, we canceled over 2,700 surgeries in a short period of time. And some of those patients have come back, but a lot of them still have not. There's this fear of coming back to our hospitals. So all of our hospitals have really been messaging, we're taking extreme care to be able to ensure our environments are clean and safe and to have our patients feel comfortable coming back to our hospitals. One of the other things that we did at Beaumont Royal Oak was to start a curbside testing for COVID-19 patients early on. And I think this was extremely helpful because our patients could drive up, they could be tested curbside versus coming into our hospital, exposing other patients, staff, and visitors. And then other sites, other hospitals started creating those, and Beaumont helped to collaborate with them to help them establish some of those policies and how you would go forward in that. Patient family center care is really a hallmark for Beaumont, and we've really worked hard at that. And that probably has been one of the most challenging throughout this whole situation with all the visitor restrictions. We always want our patients and families to be together because our families can be such support. And during this period of time, it was very hard to tell families and patients who were critically ill, families can't come in. So we had to look at other opportunities with iPads that were donated from our communities, and thanks to them for doing that. There were so many things that were donated. We had caring companions where we had people calling into our rooms because some of the patients were just quite lonely being in a private room by themselves for long periods of time. We did daily communications with family. We had patients that were critically ill. We would allow some very, very minimal short visits, and care packages that were brought in for the community was also helpful. Communication was extremely key at this time. Messages, and my colleagues would tell you too, were changing, and CDC guidelines and Michigan Department of Public Health guidelines were changing daily and sometimes hourly. And that was really hard for our teams to really make sure that they had the most up-to-date information and why we were doing things. You know, why we were, if we were wearing masks, and which patients and which areas we were moving into and which units we were developing as COVID units. It was really important to have that. We also communicated twice a day with our emergency operations centers, and we met and discussed what was happening at other campuses, and we were learning best practices from some of our other campuses and how we could best implement. Caring for our employees, as you also heard, was extremely important. We had amazing employees. We had employees that were working not in some of the clinical areas, and when we ended up going through the processes with some of the changes we had with employees going off ill, we had to bring nurses and people that maybe were working in an OR. Now they were up on the floors taking care of these patients, and there had to be training. We were training our staff on the personal protective equipment. Even though we're healthcare providers and we've been trained how to wear the equipment, when you're in a crisis situation, you're wearing it all day long, and sometimes there can be some things where you just miss a step. So we had people out watching our other employees to make sure they were keeping safe and putting on their protective equipment appropriately. A lot more support for staff in terms of meals. Thank you to the community for doing that. We would create quiet areas of respite. The emotional support was important, and spiritual support so important, because our staff are dealing with death and dying on a daily basis. And I think that was one of the most heart-wrenching and hard things for our staff to deal with. And not only were they worried about their patients, and they were so committed to their patients, they were worried about their families. When they left here every day from work, they could go home with the risk of exposing their families. We also, as our colleagues had talked about, have created some housing within the community, partners for us to have housing for our patients, or for our employees rather, and that was, I think, extremely helpful. Childcare issues. Childcare centers were closed. What do our employees do with our child or with their children? So we actually had college students, some of our employees that actually started caring for families, children in their homes. And the work from home, another huge piece. Did a lot also with telemedicine here at the hospital. We really relied on our communities too, as you also heard from my colleagues, for GM masks and face shields that they donate to us. We had local breweries that donated hand sanitizer, isolation gowns, and many, many businesses that kind of repurposed themselves for us during this period of time, I think was extremely helpful. I think the thing I think from the community, just such the outpouring of support, it was food for sure, messages, cards, signs on our front lawn, notes, financial donations. And I can't tell everyone that's on this call today how much that really helped in terms of those notes and messages. Our staff felt they were not alone, and that was so important during that time. I rounded from the day that we had our first patient on March 13th all the way, and I'm continuing to round on a daily basis and coming in at different times of the day. And it's just been amazing to see the dedication of our staff, how they've stepped up and stepped forward to care for our patients during this period of time and each other. And I think that's just been so important. So the question about what's the new normal? I don't think any of us know what the new normal is, but we're trying to work through that at this point. And how are we keeping ensuring that our safety of our employees and community members as we transition now to our new normal? We're going to continue with the employee and visitor screening. Since the beginning of the pandemic, Beaumont instituted strict employee and visitor screenings before entering any of our sites. This was codified by the governor's executive order, and it's something we're going to continue to comply with. And I'm not even sure. People ask, well, when are you going to lift visitor restrictions? And in my perspective, it's going to be quite some time before we lift restrictions, because on a regular basis, we know that we're going to have to manage this. Additional safety measures that we're taking to ensure to reopen some of our services so that our patients feel comfortable coming back. We are doing the social distancing, as you've also heard. 60 days after we saw our first COVID-19 patient, the patients who have delayed care are more than comfortable coming back. You may have seen some of the advertisements, commercials, just trying to really tell people how safe it is to come back to our hospital. When patients arrive and visitors, they're all being screened, temperature checks, they're being required to wear a face mask. Anyone with COVID-19 symptoms, we're not allowing to come in for any type of for visitation. If they're there for care, then we have them masked and taking them directly to separate locations. Additional spacing, we're allowing 6-foot social distancing in our waiting rooms and other public areas, and we're trying to create no waiting because we don't want our patients waiting. And contact with our team members during the visits is as limited as possible, but necessary to provide that care. Staggering appointment times, just a lot more things, and making sure for sure that we are disinfecting all of our sites. And finally, as I mentioned earlier, I just can't thank our community for all the wonderful things that they have done. As I said, the messages, meals, notes, and so forth. And the takeaway that I'd like to have for the community members to know is it is safe to receive care at any of our hospitals. Don't wait. Please, if you need to have care, please come to one of our sites. Telemedicine, we are using telemedicine just as many others are. We have urgent care centers. There's lots of opportunities for our patients to receive care. And during the past few months, if you've heard, there's been a lot of very poor outcomes in the community because people waited not to receive care. We all want you to know we're here for you, and we need to get these messages out to the community. Continue with the visitor restrictions, our screenings, our masks, social distancing, and avoiding large gatherings. And I know we all keep saying the same thing, but I think if we say it 10 times, we need to just all keep saying it because that will make a difference. And then I think lastly, for all of you, I know many of you are probably opening today or in the next few days. what can businesses do as they begin opening up? And we're having more people moving about. We really need to be diligent and not get lax. Continue, I would recommend to monitor the Michigan Department of Health and Human Services and the CDC guidelines. Beaumont, as you heard from some of our sites, do have hotlines. If you have questions, we're here for you to actually have you whatever you need. Encouraging when your people are coming into your businesses, masking, social distancing, wiping down surfaces regularly multiple times a day. The other thing, make sure you have trash receptacles at your entrances and exits, because a lot of masks get thrown all over the place. So putting them in those receptacles is really important. Your waiting areas, limit and avoid opportunities for congregation, and communicate with people. For your own employees, I would highly recommend at the beginning of the day and at the end of the workday, ask them how they're doing. Many people are fearful. They're coming to work. I've heard some things this morning when I was coming into work about people being scared to come back into restaurants and so forth as employees. And a lot of times you don't realize how much people have been off work for a period of time and how much that really impacted them. And I think just keeping those lines of communication open with the employees is extremely important. Until we have a vaccine that's developed, we're going to be living and working very differently. And finally, I just can't tell you enough how much I appreciate all the outpouring of support. Thanks, Jean.
Thank you, Nancy. Thank you so much. And I think I'm going to go to some of the questions that we have right now in our chat feed. And the first one we'll talk about is the one that addresses what you see being different for cancer screenings in the future at your locations now because of COVID-19. Do you see any barriers? Are you all providing these types of screenings now? And how could your local American Cancer Society staff help with the process?
Do you want any of us to take that, Jean? How do you want to do this?
Shannon, you mentioned in the chat feed you'd like to talk about it, so I'll turn it over to you.
I don't mind. And I think we've all mentioned that we've started to bring more and more patient activity back to our campuses. And so screening tests like mammograms, like colonoscopies are really important. In fact, when we were talking together as a team within Trinity about ramping back up to bring scheduled procedures, we talked about how those screening tests can make a world of difference in a patient's outcome. And so we have started scheduling mammograms and screening colonoscopies. We started doing this actually a couple weeks ago, and our processes are different, and I think where the American Cancer Society could be helpful is twofold. One, help us to encourage people to come in and have those screening exams done, particularly patients that have a family history of cancer or are at high risk. Two, remind folks that, Nancy spoke, I think all of us mentioned all the things that we're doing to keep people safe when they come into our facilities, both our non-hospital based facilities out in the community as well as our hospitals. So we've all got different waiting rooms, social distancing. Many of us are putting processes in place where a patient really doesn't have to wait. They text when they arrive, they're met at the door by a staff member, their test is done, and they go home. So we have adapted our processes. And third, also, we ask for some patience from our patients, because this is new for us. We're adapting to a new way of working, and at the end of the day, these are people taking care of people. And I know that our healthcare workers really ultimately are driven to do this work because they care deeply about those that they care for. So if we could just exercise some patience as we adjust to these new processes, it would be very helpful. But we are absolutely, and whatever else, Gina, if from the American Cancer Society, if you want to talk with any of us further, we'd be happy to gather.
Great, thank you.
Mm-hmm.
Okay. Other responses? Chris, Margaret, Nancy?
Well said. Nothing else to add.
Okay.
Shannon was very eloquent.
Yes, she was.
Thanks, Margaret.
All right, very good. We'll move on to the next question then. Has the pandemic changed any plans that you have had for designs that are already in place for expanded areas to the hospitals? And how so?
This is Nancy. I can speak to that. What I can tell you is that, as you all heard, we're all been challenged financially over the past many months. So particularly at Beaumont Health, we put all of our major projects, for the most part, to the point where we're looking at all those right now and determining which ones we may move forward and which ones we may not move forward at this point. But we're looking at everything extremely carefully.
And I would add in from Ascension sites in Michigan, including the 2 that I'm responsible for. It's really, as Nancy indicated, a reprioritization of what's on the docket. And I would say one thing that a consistent theme in our discussion today was where is it most safe, or where is it perceived most safe? And is that in a hospital setting or an ambulatory setting? So should we spend more time talking about our ambulatory settings and look at our growth opportunities? And that's not a new idea, by the way. That's been ongoing for the better part of 5 or 10 years, but there has still been a reluctance to allocate funds towards our ambulatory settings. So I do think you'll see more of that, probably from all of us over time.
Hi, this is Margaret. I just want to expound on that. I think not only design of the facilities, but one thing that one line of business that did not decrease for us was our oncology patients who needed chemotherapy, needed infusions.
Yeah.
And I think we had to do real-time social distancing and figure out how to, if you have 50 patients that need chemotherapy in a week, how do you do that? So we had to be very imaginative in terms of our hours and the rearrangement of the chemotherapy areas and the chairs, and as well as, the gowning and of both keeping our staff safe as well as the patients. So I don't think it's just the future. I think it's, going forward, how do we do our existing businesses and our existing footprint?
The only thing I'll add, so similar to my colleagues, the financial impact is causing us to reassess use of capital dollars and how we pace that spend for investment in infrastructure. And I think, Chris, you said this as well. Part of this is really giving consideration to what do our hospital facilities need to look like? How invested are we in community-based care? How is telemedicine as a modality going to continue to be an enhancement to how we provide care? And so perhaps rethinking how that footprint looks and feels is another important component as we assess construction within our healthcare facilities. And then lastly, I think the other thing that we've learned, the more flexibility you have within your care environment, the better and more quickly you're able to adapt to different kinds of patients. So availability of things like private patient rooms and negative pressure and all of those things allows you to kind of bring up an emerging illness unit and cohort patients together. And it's very, very easy to do it when you've got space that is universal in design and flexible. So that's another thing that we're all kind of thinking about. But I think the biggest pressure we're probably all under is this economic impact and need to really assess capital availability.
All right. I'm going to move on and shift gears a little bit to patient advocacy and patient care. And we have 2 questions that are similar, but a little different. One of them obviously is about, from Elena at Rochester, how are you able to accommodate patients who need a patient advocate with them while in the hospital? For instance, someone with Alzheimer's or dementia who needs a family member. And I believe that we had someone else who actually said that starting next week that a new patient being admitted can have a family member with them. And so just getting interested in getting your feedback on situations like that. Nancy, I see you're unmuted if you wanted to try.
Sure, I'd be happy to adjust that. As you know, that the governor executive order had put some very strict restrictions in place, and yesterday there was some change that I think myself and all my colleagues are kind of working through those right now. But one of those would be in terms of possibly allowing a family member or a support person really to be with the patient, particularly in some of those specific situations. So we're working at some guidelines right now to really look at how we can accommodate. Particularly though, we have to look at anyone that would be coming in as a support person, following specific guidelines. They would be masked, they would be screened at the door just like anyone would be, escorted to that patient room, and then we would be asking them really not to be moving about the hospital at that point. So we are trying to finalize those guidelines right now as I speak, actually.
Excellent. Others on the panel?
So the patient advocate question, there's provisions to allow, if there's a patient that needs somebody with them because of the circumstances that were described in this question, even the restricted visitation guidelines allow for that. So we have all been honoring that. But the guidance from the Michigan Department of Health and Human Services is what we'll all be following as soon as we're able to do so. And I echo Nancy's comments that, not having family for patients has not been easy for anybody. So I think we're all looking forward to being able to support our families in that manner.
And this is Nancy again, and what we've been encouraging, please reach out and contact our hospital. And I think looking at individual situations one-on-one where we need a patient advocate and so forth, we are more than willing to work with our families, absolutely.
This is Margaret. I think just, even before the recent change, we were, and I'm sure my colleagues were too, with high-risk patients, we had end-of-life patients that were non-COVID, so we were allowing 2 family members. And when surgery started opening up a couple weeks ago, our surgery patients were allowed 1 consistent family member post-surgery. So I think we've been easing into this, right. But again, we have to do what's right for the patient. We can follow the guidelines, but certainly it is sometimes prudent to make exceptions.
Chris, any thoughts?
Nothing further to add other than there will be 2 sets of rules, one for COVID positive patients who are in our hospitals and a different set of visitation rights for those who are not COVID, which would be the vast majority. But I echo what has been said. It's generally going to be a 1-for-1 situation. I think in the next 24 hours, we'll have it all finalized.
Excellent. Okay, shifting gears slightly, I'm going to skip the second wave question and jump down to the question about the shift to the ever-changing environment and how you anticipate employment demands adjusting. And I know that you each touched on it just a little bit, but maybe if you want to talk about how educational institutions can best help advise students to help you fill the shortage.
So I'll start with this. We've been in touch. I think all of us are, affiliated with the major universities in southeastern Michigan. And they were just as confused as we were in the beginning in terms of, how do we do rotations? How do we fill our nurses' required clinicals so they can graduate? Likewise, a lot of the residents were redeployed during the height of the crisis to places where they were not very comfortable. So I think, we're working with the School of Nursing for instance, with Oakland University. How do we get back into the rotations? How do we help them with getting their core requirements of clinical hours completed? So I think it will be a new normal, but I think there will be a chance for collaboration and ways that we can keep the students safe, but also give them, as Chris said, non-COVID patient experience.
And I agree with Margaret. I think another reason why a lot of us were not having students come anymore, some of it was from the schools, but other reasons is just to preserve the PPE. We were all struggling with, making sure we had enough PPE, our gowns, gloves, and masks. And I think at this point, we also at Beaumont have been working with the schools and universities to really work at bringing employees back to work, or not only employees, but certainly students. And I think that the pieces, though, that we have to really do, we have to do things a little bit different. Students are coming into a very different environment than what they had previously. So taking the time to educate them, and also just being available. And also a lot of times we have large orientation groups. Well, we really can't have those large orientation groups, so it's using technology like Zoom and other things right now. I can tell you, I think I've gotten pretty savvy with Zoom and all different technology, because we've been using so much of this, because our meetings are much, much different than what they were in the past, and they will be for educating students. Beaumont Royal Oak has about 400 residents, and we have a whole new group of residents coming in for their next year in July. And so how we're educating and orienting them to come through is much different than what it has in the past. And we've already started it, and they've actually really liked it. And because our students, they're a lot younger than me today, and they're really savvy with the tech things. So it's actually worked out extremely well.
Chris, Shannon?
No, it's interesting that we're doing all the graduation ceremonies, including for residents, have been canceled. So I'm doing a goodbye video tomorrow and a hello video for the new residents starting. So that's all new for all of us. But I agree with Nancy. The technology piece of this, there are positives along the way that'll become part of our life forever here.
Yeah, Margaret well said, and Nancy and Chris as well. I think we're all in the same boat. We have been talking about keeping that orientation process virtual to the extent that we can, because we think there's some value in it. I think in terms of jobs that we need, the list is probably still the same as I think about it. Nurses, particularly surgical nurses, some of the technical positions like central sterile processing techs, those are still very, very critical jobs. And this period of time of not being able to have students, the thing that I think we all probably feel badly about is what a great learning experience for students. And it would have been nice if we had been able to expose them and keep them safe and preserve our own PPE, but it became so difficult so quickly. But I know our medical residents in particular, they loved being present during this, because it's truly, hopefully, a once in a lifetime learning opportunity for them.
Thank you. All right, very good. So I think these two questions might go slightly hand in hand, but I think, one of the things that people are asking is specifically about what will go smoother in our hospitals if and when there is a second wave of infections. And then while you're addressing that, possibly talking about how social media is such an incredible medium right now, and wondering how you continue to manage the real fear and or avoidance of services and bad press and personal experiences, et cetera. And looks like the feedback is that they're finding neighborhood blogs and various social media venues are being inundated, and the need to manage this negative messaging is vital for the survival of all businesses. So, as we head into a potential second wave, how could we also address maybe the social media aspect of that too?
I can address the first part of that in terms of, are we better prepared, or how would we react different? Keep in mind that we started the pandemic with 0 patients. Now, maybe sadly, we're at about 20, our inpatient census is about 20% of what it was at its height. So the bad news, if there is bad news, is if we do have a resurgence, it's going to be starting from something higher than 0 in all likelihood. The good news is we've been through the process. All of our hospitals, for all 4 of us, we now know where the patients will go. We've converted a lot of space, and then converted it back. So it's the surge, the resurge, and the demobilization in between. So we know where we will surge into for COVID patients, in particular expansion of our ICUs. That will happen much quicker. Also, the availability of pharmaceuticals that are in trial We'll be further along in the trial of that. There was great learnings from our clinicians during the first 2.5, 3 weeks, especially our ICU, our intensivists, the pulmonologists, when to vent, when not to vent, for our ICU patients, our most sickest patients. So we are incredibly smarter now than we were on March 12th, in both in terms of from a facility standpoint, a clinical protocol standpoint, and really a calmness. I think that we would be well prepared.
I agree with what Chris said. You said that really well, Chris. You know, watching clinicians come together in teams very quickly around this crisis and learn how to do things that they, you know, previously didn't know. I mean, these physicians and nurses and respiratory therapists were learning about the value of proning patients with COVID at the same time that you were reading about the value of proning from some of the articles coming out of New York. So we know so much more now than we did, and I think we'll be much better equipped to respond if and when a second surge comes. We know our protocols and our processes. We know how we designed the units where we cohort so that we have zones where PPE must be worn at all times. And our teams just, I don't know that I've ever been so proud to see groups of people come together and work together really, really well. In terms of the question about social media, I agree with whoever wrote that in. It is the most valuable way to reach lots of people and send a message. And even to the extent that our leaders share with their social media groups some of the messages that we post, it spreads so quickly. So we've been within Trinity and within the St. Joe's Mercy Health System pushing a lot of messaging through our social media channels, and you'll see us continue to do that. It's frankly a lot less expensive than the big media buys, and I think the readership is greater, and particularly for the younger generation of patients that we care for, much of their activity is typically spent within social media space, so it's a really good way to reach a lot of people. Thank you for asking that.
Margaret, Nancy, looks like you're unmuted.
This is Nancy. I think the one thing I think I'm reading part of that question, it says inundated with some negative messages too, and unfortunately that's what happens with social media. And I think the thing for us to do as hospitals and healthcare leaders is really to get the more positive messages out there. And I think we've tried to do that in so many ways, whether it's on TV, whether it's radio, whether it's on the social blogs. But I think those are the things that we just have to keep doing. And as business leaders, we need your help with those positive messages and really staying focused on the masking and, the social distancing. And I do have concerns because I think we're all out in the community. And as we start to reopen up, I'm not seeing a lot of that in certain circumstances. And I think we as leaders really just need to be out there and show that leadership.
Thank you. Margaret?
I have nothing to add. My colleagues have really covered it. I think I agree with Nancy. Social media is great, but social media can also have a negative impact, especially with fear-mongering or, a family member that is distressed because they couldn't get in to see their patient and not understanding that, there are state guidelines. So, it's going forward. I think it will be a positive in terms of getting the message out there, but there's also a double-edged sword with social media and Facebook.
Good feedback, all. Thank you. All right, next, and Margaret, why don't you kick us off if that's okay, not to put you on the spot, but while you're unmuted. If you could go back to March, is there one thing that you wish you could change that you had done or possibly redo? And I know you actually, I think during your presentation talked about this, a little bit, but I welcome getting some feedback from all of you about that, just as far as thinking back in any particular capacity or aspect with the hospital.
I think in the beginning, because we had not gone through this, and I'm sure my colleagues experienced this to an extent, but there was a disconnect between the local hospitals and with some of the messaging in our corporate offices. So that led to some confusion, even with HR policies, and our employee health, the length of time people should stay off. I think it would be, if we had another surge, I think we have the testing in place now. I just don't think that we were prepared, both in PPE, in knowledge base, and with the testing. And I think if we had had some preparation, we would have been a lot more proactive in our action plans, our incident command center, and then deploying staff. I think lessons learned going forward, that will help us this winter if we see a resurgence. I hate to say it, but when the county was determining who should be tested and who wasn't, because there were such limited amounts of COVID testing, that really put all the health systems into kind of a questioning game. How long do we keep the patient in? How many of our staff are going to be exposed? So I think that was really a critical factor, that if we could have done something differently in terms of having availability of testing, that was, for me, the most critical factor of waits and delays.
Yeah, I would agree, Margaret, with everything you said. It wasn't just what we could control in our hospitals that we might do a little different, and we will be smarter the second time around. But testing and PPE were the biggest deals. I mean, you heard about them every night on television, actually, across the country. So the availability of those, and then who could be tested and who was a patient under investigation, a PUI, really created so much ambiguity that delayed some of our patient placements longer than it should have, and also created a bit of fear among our staff for all the reasons that have been articulated in today's presentation. Again, we'll be better off. We've used this period of less volume to stock up. All of our health systems across the country, those represented here today, have done that. I think there's enough ventilators in this country this time around. That was the other rate limiting factor. So in the communication process, we had similar things, Margaret, that you experienced in terms of what the statewide HICS command center was doing versus what we were doing. That within 2 weeks, that did get better. So I expect that we'll repeat those, frailties. But I will say the one thing we'll do faster is the team-based care that I think Nancy brought up, because we did not have enough ICU nurses. So to handle the demand, especially when we expanded into other areas of the hospital to have ICUs. So using that team approach required a bit of training. I wish we'd have done that training faster. This time around, we'll be ready to do that.
Excellent. Shannon, Nancy?
My colleagues did
go ahead,
go ahead,
Shannon.
Nancy.
No, go ahead, Shannon.
Okay. Margaret and Chris, you both did, again, an excellent job summarizing. I think, the one thing that I really wish would have been different from the beginning was testing. I know Margaret spoke to this and Chris did as well, but the ridiculousness of waiting 10 to 14. There was one patient that it took, I think, 23 days to get a result back on. It's just unacceptable. And thankfully, we have our own testing capabilities now within our health system and a rapid test available at the hospital, so that will not be an issue into the future. But that's one thing that I wish could have been handled differently. It was unfortunately out of, I think, our immediate control. And the other probably lesson learned, and I think the team here did an exceptional job, but don't ever underestimate the value in communication that happens regularly, meaning 7 days a week for a long time, because that really made our ability to adapt quickly possible. We've all gotten really good, as Nancy mentioned, at virtual communication. It probably would have been good to be really good at it before this thing hit, because we had to adapt it really quickly, but that'll help us into the future, I think, as well.
And I agree with all of my colleagues on everything that they've said. And I think what we've been able to do over the last 12 weeks basically is put a lot of processes and best practices in places. I think the other thing that from not just from Beaumont, but for all of our health systems, I think we early on were really functioning as individual health systems, and as time went on, our senior leaders were collaborating at a state level, helping to advise the governor early on. And I think then at that point, then we started really understanding and trying to help each other out, especially maybe when one hospital got a little bit more overwhelmed with patients. We've had patients that were transferred to U of M or to some of our other our hospitals. And I think that really helped with some of that balancing of critically ill patients. And I wish that would have been done earlier on, really early on. And I think that's something that we have a better plan for going forward.
Excellent. I want to be respectful of all of your time. And I know we have a handful of other questions here about hospital occupancy, with it being too high with overflows, continue to be. Now, is it continue to be too low? There's question about winter flu season as far as sponsoring influenza immunizations. And then at some point, should everyone be tested if you now have symptoms? And so what I'd like to do is give each of you an opportunity at this point to pick one that you would like to address and maybe make some final comments so that we're respectful of your time and we can end on time. So Nancy, while you are unmuted, if you would like to go first, I would be happy to have you do that.
Sure. Let's see here. I think that the testing piece is always still a challenging. I know a lot of employers are requiring or requesting their employees to be tested. But I think the thing that's key, a test when it's done is only a point in time. So if I could have a test done today, and it could be negative, it could be done in 2 more days, and it could be positive depending on exposure. So I think the whole piece around testing is really critical to really understand. The other thing is, even though we have more testing sites, it's still, there still are challenges with testing kits and reagents and so forth. So I think the whole piece around testing, we all need to really do a lot more work on that and really make some good decisions on who really should be tested or who should not be tested. And I think the individuals that are most effective in being able to do that is, I would encourage people to talk with their physicians. Their physicians are the ones that can really advise them on whether they should be tested or not, and really looking at what is their scenario. Have they been in situations where they've been exposed? Those are the types of things that I think our patients and really need to ask.
Excellent. Chris?
I could take the occupancy one if that's, I know it seems like we're never happy. We're schizophrenic. There's too many patients. There's not enough patients, but it's a little more nuanced than that. So during the height of COVID, it was our ICUs that were overrun, and the availability of PPE, equipment, staff to handle that. The rest of the hospital, gradually the census went down, actually in some cases not so gradually. So now the ICUs are back to a manageable state. And I would say, and I'd bet these percentages are fairly close to what the other health systems here today would report, but our emergency departments are at about 60 to 65% of what their normal was pre-COVID. Our inpatient census is at about 70%. And our surgical boards, our surgical scheduling, both inpatient and outpatient, is just slightly less than 60%. So I think that will come over time. There will not be an issue with beds, but I'll give you one caveat to that. And it was said here several times, to be safe, patients are going to want to be in a private room or feel safer. They're going to want to be in a private room. So can we accommodate that at all of our hospitals? Some of our hospitals were just not built for private rooms. You can always have a private room by just taking a semi and making it a private, but that cuts your patient occupancy in half. So that'll be a challenge as we go through, especially the flu season and next fall, and then the respiratory illness when we get busier. So kind of stay tuned for that. Right now it's okay. We're building back up. It'll take us a couple more months to do so. And my parting comment is just a thank you. Thank you for this opportunity, but also, as mentioned here today, the outpouring of support from businesses, community members, individuals. It's incredible, both in terms of meals. We had lots and lots of meals, and we're forever grateful. So thank you.
Shannon?
So do you want me to take is there a question about influenza? Am I right, Jean?
There is, sure.
Yeah. So, as we read about the potential of a second wave, we anticipate that could be concurrent with our typical influenza season. So you see a rise in respiratory infections during that time. There's high potential that there'll be a rise in COVID during that time as well. We are lucky in that every year there is an influenza vaccine available. Its effectiveness seems to change from one year to the next. I know all of the health systems in Michigan, at least I think that this is true, mandate influenza vaccines for employees and for physicians. I think we're all doing that. And you will see us messaging on the importance of connecting with your primary care physician to get your flu shot. If you don't have a primary care physician, any of us could help you to align with one in any of our health systems, and we'd be happy to do that. But, particularly now during this time of lots of confusing information out in the community about COVID and people doing a lot of their own reading, sometimes of reputable sources, sometimes not, the importance of having a health system that you're partnered with and a physician that you're partnered with is important. For those that don't like to make time to go to the doctor, this new telemedicine access is going to make it that much easier for you to make that connection. And so if you all can help to drive that message home as we prepare for who knows what the flu season will bring, getting a flu shot this year, I think is going to be that much more important than it typically is. And I also echo the thanks. This has been wonderful for us. It's wonderful to see the engagement of this group. I think it's, during a time like this to see a community come together, there's really nothing better than that. And we got to stick together because this might get difficult again. So thank you.
Thank you. Margaret.
Jean, what leftover questions would you like answered?
I think you could probably pick your favorite.
Well, I'm just going to say one thing that our health system isn't good at and we don't have a good infrastructure for is prevention. And I will say that I was at a meeting, and I won't say where today, but several of the people in the meeting didn't even bring masks in. So it's America's tendency to be sort of the microwave country where, it's one and done and we're going to move on and it's summer. I think we as healthcare providers and the community providers need to be vigilant in, the most basic things, the social distancing, the masking, and just prevention. Because if we get used to that and it's a habit, and we integrate it into our daily routine, then it's not going to be, a very big inconvenience when the weather gets colder and the flu season starts again. But if we think that this is not going to affect us, then we're going to make ourselves vulnerable, and we're going to see a spike that we don't want to see in six to 8 months. The other thing that I want to say is, in healthcare, sometimes we become insulated if you're not talking to your colleagues, and sometimes we think that talking to our competitive collaborators is not, acceptable. But one of the things that got me through in the early days, and thank you, Shannon, for this, Shannon and I would have informal phone calls or text each other saying, what are you seeing? What are you doing? What are your best practices? And we were free to share that. It wasn't like it was a, trade secret. And I took some of her best practices and she took some of mine. We shared some of the PPE. If I was short, she offered to give me some. If she was short, I offered to give her some. So I think that this is, this isn't an individual sport. This is a team sport to try and protect our, our stakeholders and our population. And thank you for allowing all of us to be on here and speak to the chamber.
Thank you. Thank you, Margaret. Thank you, Chris, Nancy, and Shannon, all of you. And you have an overwhelming support and thanks in the chat feed in case you haven't seen it or looked. But we all very much appreciate everything you're doing in this fight. So thank you again. And we hope to do this again with you in 6 months when we all have an opportunity maybe to do it in person, but possibly even to just get an update as far as other changes and positive things that have come about from this. Thank you so much.
Great.
Thank you.
Thank
Thank
you
you.
very much.
Bye-bye.
Bye to my colleagues.
Bye.
Bye.
Good to
Bye.
see you all.
Thank you. Take care.